Let me now briefly introduce Dr. Dipak Kalra, who is here from the UK. From many perspectives, I'm delighted that he's here and will be speaking with us. In case it hadn't dawned on you, there are a very large number of activities ongoing, not just in the UK, but throughout Europe, and in fact in the rest of the world, but we're going to be focusing on Europe here in the next session, that bear very, very close relationships, if not outright overlapping relationships with what we are talking about here in the MCBK meeting, and as we think going forward what we might do with the MCBK movement. We agree that there is an enormous potential to join forces with our colleagues in Europe to strengthen what we do, to learn from each other, and to go forward together. So there is no better person than Dr. Kalra to speak with us, to us, and answer your questions about what is happening in Europe. He is the CEO, and I want to get this right, the president of the European Institute for Innovation through Health Data, and in that capacity is uniquely situated to give us these perspectives. Dr. Kalra is also a professor of health informatics at University College London, and also a visiting professor at the University of Ghent. So Dipak, thank you and welcome.
Good morning, everyone. So thank you, Chuck, first of all, for inviting me here, inviting me to come and speak to this group with whom I feel a strong synergy and career history, even if I don't know a number of you personally yet. Challenging to summarize Europe in a short space of time. And so what I will just tell you up front is that I agreed with Chuck that I would actually, there's a set of slides that are hidden that are not going to be presented this morning that give a cook's tour, a tapas or a mezze of a number of people and what they're doing in Europe. And we decided that in order to make best use of time, I won't walk through all those slides and do savage injustice to all those lovely people whose work is compressed on a slide, but the version of the file that you are able to access later will include those slides, so do please look at those later. What I felt I would try and do today for this group, and especially even more mindful having sat through yesterday and felt the tensions and issues we're grappling with, is I'd give you a few slides of context setting. What are the big momenta going on at the moment in Europe that are enabling for computable medical knowledge? And then I'd like to give you some lessons learned, some challenges, maybe even be a little provocative based on some of the findings from some of the European projects I've been involved in. So I'd like to treat it in that kind of way, and let's see how we go. I guess I just click away. No, not that one. This one. Okay. So let me start with Germany. I'm picking on Germany only as an example to give you a flavor. A number of European countries are now or have recently launched major pan-national health informatics or medical informatics programs. And I'm picking on Germany because it's one of the latest to be announced. It's just got started and is 150 million euros spread out mostly over 4 European clusters. The aim is to bring together the capabilities to learn from and use learning from data at a regional level within 4 parts of Germany to further quality and safety of care improvements and research by bringing data together that can allow for richer inferences to take place. Now, this is fascinating because there is a limited amount of control on those 4 regions, except the mandate. And so what we are already seeing is they are using somewhat different topologies of federated to centralizing the data. They're using different interoperability standards to try and achieve that data harmonization. And so these will become 4 fantastic incubators to learn from over the next 4 years. But they are stimulating demand and hopefully will generate evidence of value of why bringing research and care together in a joint learning environment is useful. But these are, if you like, customers for computable biomedical knowledge, because they are about to put such knowledge assets into practice. Stepping up to a pan-European level, I'd like to bring your attention to the second of a pair of successive IMI projects. The Innovative Medicines Initiative is I think, the world's largest public-private partnership program. So these projects are sitting around the 30 to 60 million euro budget zone. And this is the second project. I was involved in the first and not involved in this one, which is looking at establishing large-scale big data federations across Europe of health data from hospitals, from registries and other data sources to support learning. And the previous project was more methodological. What are the right tools? What are the right models? What are the right governance frameworks that could enable an acceptable federated model across countries? And this project is now going to scale that up. And I'm not going to elaborate on it, but to let you be aware that this mission of scaling up big data assets at a pan-European level is gaining momentum, it's gaining funding. This pan-European program may eventually intersect with the national programs to even further scale up. This particular approach is going to be using OMOP as its data warehousing data model, just for your information. Then if we go to the world of clinical trials and conducting clinical research studies, a project that I led that has finished, called EHR for CR, established an appropriate mechanism and now a commercial entity that is scaling up delivery of a federated platform that can allow those people, for example, inside a pharma company, who are constructing a clinical trial protocol to execute distributed queries and understand the potential availability of eligible patients across Europe, how many would meet a set of criteria, and where roughly are they located in Europe, in which health centers could you find such patients, and can you fine-tune and fiddle with your protocol criteria to optimize the likelihood of recruitment. And then, hexagon number 2, can you give to those hospitals the query so they can run that same protocol query in-house, privately, to case find candidates and proactively approach them for recruitment, rather than today's practice, which is to wait for people to pitch up in clinic and hope that somebody will remember to ask them if they would like to be in a clinical trial. So to optimize the protocol and then to accelerate recruitment into that protocol are now being deployed at scale in Europe. And my institute's role is to provide the governance environment independently to that ecosystem. Then on the right-hand side, the last pair of hexagons is a project that is ongoing, which is to tackle the next challenge around clinical trials, which is the redundant data entry that occurs in clinical trial systems from EHR data because these systems don't talk to each other. So can we get them to talk to each other, and can we export from an EHR under full trial investigator control and with fully informed patient consent, their medical summary and other key data, so that the trial system can be populated efficiently and much more accurately than is currently the case. So on that study, on that project, one of the challenges, of course, that we face, which surfaced a lot yesterday and was even mentioned briefly this morning, is our lovely standards mosaic. How many standards do we have? How much fun do we have mapping between them? The current tendency in Europe is not at the moment to say, here is the best one, let's stick with it, but rather to build up the capability of being a little better at being standards agnostic. So, for example, at the moment, there are a diversity of standards and infrastructure sitting inside each hospital. So to scale this up, we've got to deal with heterogeneous EHR systems. And you see things like the FHIR logo, the SNOMED International logo, LOINC. You see these worlds, WHO, ICD. You see that landscape that sits in the health world. And then you see on the right-hand side of the slide, CDISC, which is the standards body used where it is used by pharma to support regulatory submission. There's not much traction to change that landscape. CDISC is the standards body that is strongly endorsed and highly tuned to that purpose. Odyssey and the OMOP model, very attuned, as we've been discussing yesterday as well, to other kinds of observational big data research. So we can't harmonize that world, but we can bridge across them, and that's really the landscape that's now being pursued more in Europe. And if we look at that process of developing the interoperability infrastructure to do that, we're starting to see, and this is just an example of a clinical information modeling community and tool, where they have already recognized that it's no longer suitable to just be able to develop clinical models. You have to look at translating that clinical data specification into a series of different exploitation pathways across standards in order to allow these models to then be used in a diversity of settings. Because what matters about the clinical model is not whether it is represented as an open-air archetype, an ISO 13606 archetype, or an HL7 FHIR resource. That's the least important aspect of the complexity and sophistication and value of a clinical model, and yet our community gets hung up about that, stupidly so. You can map and transform between those formats. What you can't do is map and transform between two clinical communities who see the world very differently when it comes to their data. That's really hard. So we're focusing on the wrong thing when we get het up about which standard to use. Not the most important thing. Let me come back to that. Another just brief point is that there is now a movement towards how we can make these kind of resources increasingly available. So this is a particular initiative which is building a repository of clinical models and forms as a searchable warehouse. Maybe I'll actually jump to this slide. So the medical data models portal is offering you access to 20,000 models that have been developed in different places in different ways. It's available across languages, it's available across standards. So it represents a place where you can go and find what's already been invented. Now, what I would like to do is to shift slightly to being a bit more provocative now. Our institute was created 3 years ago as a not-for-profit international association registered in Belgium as an outcome of a number of R&D projects, including the EHR4CR project that I mentioned. Our mission is to help catalyze better uses of health data, better sharing of health data, and better trust in the uses of health data. And so our role is to sit in a neutral space. We are deliberately a multi-stakeholder environment that brings together players and tries to scale up everybody's use of data. Now, you know that there are a whole series of ambitions that sit in the clinical research space about why access to real-world data is perceived as being of such great value to accelerate clinical research, but also to start to develop new kinds of evidence for things like precision medicine and value-based care. And you're very familiar with all of the reasons why healthcare wants to learn and improve using its data to improve quality and safety of care, but also to start to shift the focus of care more strongly from the professionally delivered to the patient empowered. And that's a very strong momentum in Europe right now. And of course, how to improve the quality of service and improve public health capability. So one of our missions as an institute is to see how we can bring these people together and get them to break down that boundary between them, because they have a common need. The common need is to harness the value of health data and to optimize the methods and the abilities to leverage the knowledge that's locked inside health data. So that's not just heterogeneous data, that's the means of learning from the data so that we can all benefit from insights. So the way we work is to bring stakeholders together. And when we were discussing briefly yesterday which stakeholders are missing from this meeting, if you look at this circle, I would honestly say to you, most of this circle is missing from this meeting. Why? Because this is a meeting mostly, and I don't know all of you, so I may be insulting a few of you, but this is a meeting mostly of people who are CMB, I always get the initials the wrong way around, CBK makers. You are mostly CBK makers. You are not mostly CBK users, and you are not at scale, and you are not mostly CBK purchasers of systems with CBK inside, and you are not mostly end beneficiaries of CBK capability. They have to be in this landscape for this movement to succeed. I've told you I'm being provocative, this is just the start. I'm not going to talk today about one of the big things our institute's about, which is to do with trustworthiness of data use. All about governance, data protection, privacy protection, respecting citizen choices, respecting why and how data gets used. There was a very pertinent question, or two questions to the previous speaker, Don, about ethical issues to do with who has access to the data and why they have access to the data. These are things we're really in the middle of dealing with. But that's not today's talk. Today's talk is about the knowledge representation dimension. So what do we see? Because I'm not addressing this talk with slides for this audience, I'm repurposing work we've done in the past, addressing to you. This slide is about standards development. But I'd like you to understand that when you think about standards development and SDOs and what they do, the moral messages here apply to algorithm developers, AI developers, guideline developers as well. That's why I've included this slide. I think it applies to all of you. My observation, my years of experience, and that of other colleagues tell me that this field is still too technically driven. The input from real end-user stakeholders is somewhat limited, and it's somewhat biased towards people who are like me. I was a general practitioner once. You might not remember that now. But we kind of quasi-clinicians are IT enthusiasts. We would do anything on a computer, even if it was painful and miserable, because we love computers. We are the wrong people to specify requirements. You need the computer phobics, the ones who hate computers, the ones who love quills and paper. They're the ones who need to be asked about their requirements for using ICT solutions. I'll come back to some of the other topics later. But basically, the real challenges for this movement are the red writing coming up. We keep reinventing. We keep making a better one than our neighbor made. We would rather make than reuse. Why? Because we have these two red phrases as unwritten, almost never spoken, secret drivers inside ourselves. If we want to scale up, and I would like to now focus for the rest of this talk only on the word mobilizing out of the 4 letters that are driving us here. If we want to mobilize, as in get things on the road and really move, we have to address these red terms. So I would say from this slide, we are extremely good at the right-hand side of this slide. Many of you in this room are world leaders in some of those magical words on the right. But we are terrible at the left. This, again, slide was originally created for communities of people who either make standards or design clinical models. We didn't make this slide for the AI and the guideline developers, but I would still assert it applies to those of you in the room in that world as well. But if you take SDOs as an example, SDOs, standards development bodies, and I will not pick on HL7 or ISO, although I'm very familiar with those worlds, or CDISC. I'm familiar with those worlds to some extent. I've been involved in those bodies over the years. We do have these quasi-informatics geeky clinicians. But there is not one standards development body I have yet come across who has a clear and strong and forceful patient engagement strategy. And yet, 5 years from now, it is anticipated that the volume of health data on the planet generated by patients themselves will outweigh the volume of professionally generated data. Healthcare systems are, at least in Europe, unsustainable unless they empower patients to become part of their own healthcare delivery. Therefore, they are the absolutely next users of health informatics standards, but we don't even ask them what their needs are. We should be ashamed of ourselves for our very poor engagement of patients in these things. Research and public health are barely included, except in their own silos, of course, where they have their own families of standards that don't talk to anyone else's. This is the landscape we're in. So I'm being provocative. You can always disagree with me in the question time. So we were starting to look in a number of our European projects recently at what might be good development practice. You have to start. We've seen a lot of people who will develop models and develop standards and guidelines on the basis of very flimsy input. You've got to really look at the interoperability need if you're developing things like clinical models. What are the use cases that you're trying to achieve with the models that you build? Why is it important to scope yourselves first? It's because any attempt to standardize is to require compromise. You have to compromise when you make these things. And you cannot sensibly compromise unless you've understood what you're trying to achieve. That becomes your scoping. Effectively, they become your business requirements. And I can tell you, as a requirements fan, the word requirements is the least prolific of all of our outputs. We go jumping straight into design mode without articulating formally our requirements. That's commonplace, and it's unacceptable behavior. Sorry to be rude. We then need to harness the expertise, not the one or two champions that we love who work with, who are mates of ours. We really need to look at who are the actors who need to influence the scoping and the spirit of an interoperability asset that we're making. And then, of course, we shouldn't be only opinion-based. We need to say, well, what exists out there already that guides us as to the shape of a clinical model? And I see again and again very few occurrences. And I've been in the clinical modeling world for probably frighteningly 20 years. You didn't know they were invented that long ago, did you? 20 years. I see very poor engagement with an evidence-based development pathway. But it's very rare that something that you now want to standardize has no existential presence in the world already. It's just not as a clinical model. But start by looking at what exists, because what exists might already be reflective of the needs. And then it's very important to work in a two-stream process. Work with people as well as with technical methodologies. The tools are vital, because the tools formalize wishes and ideas and thoughts. They help to visualize. Is this how you meant the data to look? But you've got to have the people on the other side. Don't think you can operate a waterfall model. This, and I maybe should have put a little arrow in the middle, this is an iterative process of saying, is this what you meant? Are you sure? Etc. And then align with standards. Don't If there are already well-established standards that formalize certain parts of the knowledge space, try and build on what exists rather than just go with whim. Consultation and peer review. When you think it's final, it probably isn't yet final. You really need to have a wider consultation. Whoever you involve in that process methodology box will be a small number of people, a pragmatic set of people, several people you can realistically work with. But that's not the adoption community. You need a wider process of peer review to really help to get endorsement and sign-off so that you can then build a community of trust about what you've developed. Don't stop there. Remember also that interoperability assets of any kind, and in fact, any knowledge assets, are almost never usable alone. So we're actually quite good at publication. We love showing off what we've done. And please forgive me, I'm going to insult you continuously through this talk, but that would provoke you to questions. We're good at the publication side. We're all good at putting things out there. Talk about GitHub yesterday. Asset bundles. What are asset bundles? They're about being transparent, about what else you might need to use to make my thing work. If you take a computable guideline or you take a piece of decision support, it leverages knowledge. It leverages data in the EHR. That means there is an assumption made by the person building the logic that there are data points that correspond to the ingest and the output of that piece of logic. They need to be specified. Maybe somebody has assumed a certain fire resource will be the data stream coming in to their component. Specify it. Maybe your clinical guideline, your computable guideline, is the computable form of a published narrative guideline. And people may want to recognize what is the guideline that you've made computable. So the assets don't live on their own. They need to be put into a bundle, either for understandability and trust, or for using. Things can't be used in isolation. Be declarative about what else is needed. I'll come to quality in a moment. Conformance criteria. If you want your models, your algorithms, your clinical models or whatever to be used out in the real world, it's going to be used by other people who pick this up, junior developers, people working in countries all over the world who may not have all the tacit knowledge you do. So formalize how can people be confident they've adopted your model correctly. Because otherwise, you're going to have heterogeneous adoption of a very beautiful standard or specification. And that won't help us solve the problems of the real world. So you do need to do that. Then, of course, there will be more specific conformance testing, and ideally there will be national, European, regional, whatever, ecosystems that help verify adoption has been complete. And please don't ever think this whole diagram is a waterfall. We don't also see, especially in standards bodies, a listening ear. I recently was just completed, published only 2 or 3 weeks ago, a revision of the ISO 13606 standard. And when I was asked to pick up that revision process about 5 years ago, or 4 years ago, I said, ISO, okay, we published the previous one. What's the process that has taken place within all of the national standards bodies that tell me now what worked, what didn't work, how well it was adopted? No such process exists. And when I try to run questionnaire surveys in member states, to national member bodies, sent them to ANSI and other bodies and said, can you send out a survey? Can you give us insights into what happened to the previous version? I tell you, it was very painful. There was a bit of a shock. No one's ever asked us to do that before. We have to be alive to learning from our mistakes, what we got right, what we didn't got right, but also evolving requirements. So another thing I'd like to commend you to is something that we've built, but it's a prototype, and it's something I would like to bring into thinking into this community, because I think we think we've done something useful, but we would like to extend its potential value and to see if we could collaborate with this community on doing something more with it. So this is an asset register which was designed for interoperability assets, but I think you'll sense that actually it could be used for any kind of knowledge asset. And very open-minded about what an asset is. It could be a legal entity like a framework, a policy, a template of agreement. It could be an adoption guideline or a training resource that is supporting the use of a particular computable asset. It could be a technical thing like an information model, an XML schema, or it could be more semantic like a clinical model, a terminology subset, a value set, etc. Doesn't matter what it is. The key thing is, can it be described? And this is a register and not a repository. We did offer an upload function, but I don't think that's a very useful thing to do. What matters is not where you put it, but how you describe it. Now, what is the basis on which we created this? Well, we started with the premise that people do not, in general, reuse. They reinvent. So we worked in a number of European projects, but a particular one especially, with a set of people who are e-health strategy leads for their countries. We worked for people who are in national health ministries, usually heading the informatics or digital health or IT bit of the ministry, or health insurers. We also worked with some big global ICT companies who make EHR systems, because they also have to help scale up computable knowledge assets by absorbing them into mainstream, globally distributed products. We work with professional bodies, some patient organizations, not enough in my opinion, but some, public health organizations, and said, okay, if somebody had a knowledge asset, what would make you reuse it? What would make you trust it? What would be the ingredients of assessing the real implications of using this? And we decided to capture these. A colleague of mine, a PhD student I supervised, Alberto Moreno Conde, his PhD is published. There are some papers that we've co-authored about this topic. So I had, luckily, a dedicated, energetic young Spanish guy to do a lot of the real work, and he did a brilliant job running surveys, running questionnaires. And what we decided was, firstly, you see a radius diagram, I'll just mention that briefly. You know, the quality of an asset is not a singular thing, you know, it's 6 out of 10. There are different characteristics like quality of the development process, its maturity level, its trustworthiness, the support and skills needed to adopt it, the sustainability of it, its level of interoperability, the maintenance burden, the cost of effort and adoption. These are the axes of decision-making, yes, no, that people told us. If it's an absolutely brilliant asset, it's stunningly fantastic thing in English, but I need to translate it into Spanish, and it's almost impossible to open the box and interweave a Spanish vocabulary, then actually I can't really use it in Spain. If I can have it, but actually the developer has moved on to another project now, has no interest, it's just sitting there, it's not being maintained, it's going to go out of date, I'm going to have to train somebody to understand this asset and learn everything about it so that we take on its maintenance burden. That may make it prohibitively expensive to use, even if it's free. So these are the kinds of issues that we surfaced through our discussion with decision makers. And that influenced how we then defined the trustworthiness characteristics of an asset. And time doesn't permit me to go through it all in detail, but I've just thrown up on screen some of these. So I'll just go back, sorry, a moment. That might be harder to do than I think. Previous, no, it's not so difficult after all. So just to say that the asset register asks everybody to fill in the same fields, unless you indicate that it's not applicable to you. And of course, apart from describing its quality, there are fields that capture, you know, who created it, when and where, what initiative, what project, is it still available, where do you get it from, who do you ask for further questions. Those kind of issues are handled elsewhere. But you see also somewhere up there it says, and links to other related assets. So this register allows you to create bundles. It allows you to say, this asset that I'm entering now relates, it is a subcomponent of this bigger asset that is entered earlier in the register, or it has 3 or 4 subcomponents that are already in the register. So it allows you to create a little network of interdependencies of assets and label them. It also captures things like co-authoring, so if you start to enter your register entry and you can't finish it, you can save it incomplete, somebody else can log in and finish it off, etc. And then we have an editorial process that allows approval of somebody's assertions. And I've cut out the editorial process. That would be a lovely discussion to have. Maybe we'll have it in our breakout group later. So things like the evidence used, the consultation process, what standards have you conformed to that are relevant, what quality processes have you used, the maturity level, what's the technology readiness level, endorsements. Have you had any organization say, we support this, we think this is great, etc. And some of the other issues I've mentioned already. I can't go through these in detail. Chuck, do I have about 5 more minutes?
We're going to have time for questions, not quite 5 minutes.
Okay, all right then. I'm going to just jump to one other topic then very briefly. And I'm going to skip a couple of slides and come to this one. Many of our interoperability assets were developed by looking at data. And many of our interoperability assets will be used with data. So data quality is an important success factor for quality assets. Data mining, machine learning, all those kind of inference environments from data will be strongly influenced by the quality of the data that's being used. So we have recognized that there is a really important value in working with hospitals and other care organizations on data quality improvement and on data quality benchmarking. So we have been working to develop not only the methods for data quality assessment, but how can we report to a care organization about its data quality so it can better understand its systematic errors in having good quality data and put in place appropriate data quality improvements. What we are now starting to work on, just at the infancy, is when it comes to research use of data, could we provide a similar kind of radius diagram or traffic light indicator around the data to say, depending on your purpose of use, certain levels of data quality might be acceptable or not acceptable. Now, we've pictured that very much for people who want to take knowledge out of the data. But what about people who want to develop knowledge assets where they're using the data to inform those assets? What is the appropriate level of data quality that you need to build trustworthy assets? That's an open question. This community would be a great place to take that forward. Final slide then, in that case, is this one. So I'm going back now to the helicopter and the context. What is the scenario for health delivery in Europe today? We have limits on the budget. Mostly thanks to a rather long ago financial crisis, we are still underfunding our health systems. So every euro or dollar spent on healthcare has to be really effective. So that's a really important driver. It's not a use case, as we heard yesterday on the panel's use cases, but it is a business driver for computable knowledge. But then the computable knowledge has to realize that one of its objectives is to help healthcare to be more effective, to be more safe. Aging population, comorbidity. How can we better leverage siloed guidelines that were all developed for single diseases, regulatory approval for drugs that were only ever trialed in single disease patients? How can we expand to meet the needs of the real ill population who have multiple diseases, who are aging, and my birthday was yesterday. I'm not going to say how old I was, Chuck might reveal. how do we get MCBK? I've done this so many times wrongly. How do we get MCBK not to be whim-driven on where is the research passion, but to be health system-driven? Where is the need to revolutionize healthcare, to positively disrupt healthcare, and to bring the magic that you're capable of to deliver societal value? Thanks very much.
We have about 5 minutes.
Okay, thank you.
Hi, Brendan Delaney from Imperial College. Fabulous speech, Dipak, really good. I like your challenges, and I was sitting there reflecting, what is it that distinguishes this community and medical informatics in general from science? And it's largely that we create, we don't discover. And when you create, people have a personal investment in it, and you get that not invented here problem. So I'll challenge back to you. How would you turn this community into discoverers rather than creators?
Well, I think that's very difficult, but one of the problems is recognition. If you invent something that is of value, if others then use it and you get credibility for having it used, that's helpful. What we actually need to do is, it's very rare that you can actually just simply adopt something elsewhere. You often need to become part of its community. And I think that the solution lies in rather than decoupling the creator from the discoverer, is to say, can we start to grow communities around an asset? So you become the founder of a community rather than the sole inventor. And the other persons using it don't become passive users, but they become members of a community, co-contributors. Because even if I take your asset and I never change it, but I deploy it in Spain, I'm adding to the evidence base that we both then have of its value for use in Finland or use in the US. That's the spirit we have to go for, I think.
Okay, Barry, we didn't get to you last time, so we'll give you the last question.
Thank you.
Now.
Barry Ginsberg, American Diabetes Association. I think you've overlooked a main source of content. I represent a consortium of American Diabetes, American Heart, American Cancer, a bunch of voluntary health organizations, and professional medical organizations. We have literally thousands of standards of care, clinical pathways, and guidelines. Unfortunately, they're all in paper form. Almost none of them are digitized. And digitizing them isn't hard. Getting them into the EMR is very hard. They're done one-off. There are no standards for how to do that. And that's sort of what we're looking to develop. And that's where we are now. I think the nice thing about this is once you do that, it's where you're going to be. That our standards are all evidence-based. But what that means in reality, if you look at them, is somewhere between 10 and 20% of them are level A. And a lot of them is still best care, as physicians describe. Once you start getting real-world data, you can move that beyond evidence of A of 10% and get it. But that's years out. I mean, that's 5-6 years out, minimum.
Well, I would agree with you completely, and I apologize that in the compromise of the length of my talk, I didn't pick on that topic. But if you take, for example, the evidence-based guidelines you've got, there is a critical coupling to the shape of the clinical data that allows for computable reasoning. And so there needs to be a family of clinical models that sit alongside the components of the computerized guidelines. And they need to be coupled well enough that there's reliability on both sides. And so what we need to see is these communities coming together. And I mean, there are people, I know them, like John and Brendan, who've been really active in this space. Forgive me, maybe others in the room, but I know both of those have been active in this space. I would agree with you completely. I can't qualify what you said. You're completely right.
Okay, Dipak, thank you so much.
Thank you very much.